I will present the tape case on the next generation cardiac plug, the Amulet. Was actually the first in man that we did last July, and we'll concentrate more on the difference between this second generation device and the first generation device, because we are going to have another tape case later today, just to show the step-by-step related to that procedure. So it's a 67-year-old woman with hypertension, diabetes, and aortic valve replacement. Was done in 2011. Chronic AF, high risk of stroke, CHADS 3, CHADS VASC 5. Refer at the time for Laaocclusion because the oral anticoagulation was stopped in the context of massive recurrent GI bleedings. So this is the baseline TE, different views as usual. You see there's a lot of spontaneous echo of contrast in the atrium. Quite good anatomy for a closure, quite straightforward as you can see. No clear thrombus, but a suspicion of a thrombus at the time. It's why we inject contrast to be sure there was no thrombus, and we find no thrombus, no evident thrombus as far as we were concerned. We were in July, it was first in man. That device was that's the second generation of the first one with few key change that I will explain after. So we were in the Abraham room at the Institute, Montreal Heart Institute. The patient was under general anesthesia. TE guidance, this is the usual way for us. We pre-close typically the vein with a suture. This is the catheter for the transeptal puncture. This is the SL1 catheter by St. Jude. We like to use this catheter to do a nice posterior and inferior puncture of this atrial septum. This is the first angiogram, typically for us areocranial, with a 5 French mark pigtail. So you see very well the proximal portion of the appendage. We were happy with the position of the location of the transeptal puncture, and this is now the areocaudal injection, showing more the distal part of the appendage, and you can clearly see there's too low, probably, but still a very good anatomy and a good landing zone for a device. This is the measurement to try to correlate the echo and the angio. So at the level of the osum, it was approximately 20, 22. There's, as you know, a lot of difference sometimes with different modalities, but in roughly 20, 22. And the landing zone, roughly 20 millimeter. It was measured 1 centimeter inside. So we decided to go ahead with a 22 millimeter device. This is the torque view sheet to deliver that device. So you need a 12 French sheet for the 22 millimeter Amulet. There's another option, the 14 French sheet for the largest 2 diameter device, which is the 32 and the 34 millimeter device. So this is the torque view 45 degree. There's 2 more sheets available, but this is the classic one here that we put in place over the wire that was placed in the left atrial appendage. You see, while the aortic bioprosthetic valve also, we are in the appendage, we're injecting, confirming the good position of the device, the sheet. This is the device. I will not spend time showing how we prepare this device because we are going to have that second tape case today. So I will go right away with the deployment. So we introduce the device that we are going to deploy eventually in the appendage. So this is the formation of the ball, this on the appendage, then the lobe. And the thing with this lobe, with this second generation device, the lobe that you are deploying in the appendage, it's larger than the first generation, and there's also more and stiffer barbs around the lobe to increase potentially the stability of this device in the appendage. The only thing is because that lobe is bigger, it takes more volume in the appendage, and this is potentially the only limitation that I see of this device is the fact that you need a lot more volume in the appendage to deploy your lobe. So you have that bigger lobe with more barbs and stiffer barbs deployed now in the appendage quite distally, and you have the opportunity with this second generation device to deploy the device more distal, and then you deploy the disc the usual fashion. You have the delivery cable still in place. There's an option with this device now that you have actually a two-wire. The cable is formed by two wire, the inner wire, which is very soft, and a second wire over this inner wire, so an outer sleeve that you can retract to see what's going to be the final position of your device after deployment. It's what we are doing at this point. But as you can see, we were not happy about the position of the device at this point because the disc is deployed inside the appendage, but this is very clear. So you have always the possibility, like the first generation device, to recapture and redeploy the disc over the ostium. But if you want to do that, you need to push back the outer sleeve on the inner wire just to be able to retract to recapture your device. And the good thing with this second generation device, the disc of the occluder is larger than the first generation, so better cover the ostium. And there's also a longer waist between the lobe and the disc. So again, giving you the opportunity to deploy that device more distal in the appendage, pull back and then deploy the disc over the ostium. Again, the evaluation of the potential final result. Again, the outer sleeve is retract, leaving only the inner wire in place. So we have a very good visualization of the potential final result. And now we were happy because the disc was redeployed, now covering the proximal trabeculation. So we were happy about this final position. And then you just need to release at this point. The other good thing with this device is the fact that the proximal disc, the screw is invert now, so it's not going outside like the previous one, to potentially increase the safety and to prevent clot formation on the device. Because it was shown that with the first generation device, most of the clot they were forming on the pin of the disc. So this is a good final result at the echo. Again, different view to demonstrate that the device is well in place in the appendage. And still a good result at follow-up. Typically, the TE at follow-up is done at 3 months in our institution. So still very good result, no thrombus, no residual leak around the device. So in summary, the amulet, it's a more simple device. I did not focus too much on this, but it will be present in the second case because it's coming preload, so it's a clear advantage. Several interesting features, including larger size device. We have now a 32 and 34 millimeter device to close larger appendage, longer waist between the disc and the lobe, giving the opportunity to deploy that device more distal in the appendage. There's also a longer lobe length. I'm still not convinced that it's a true improvement at this point, just because it will require more volume of appendage to deploy that lobe. But I think we should probably have more experience with the device to judge on that. Will potentially minimize the adverse effect. We still need to prove that also, but with that low profile end screw, we will potentially prevent clot formation at that level. And there's more stabilizing wire and stiffer wire around the lobe, again to decrease the embolization rate. It's approximately 1.5% with the first generation device. So this first in man and all the feature of this amulet is described in a paper now that we were able to publish 2 months ago. So I will certainly suggest you to review that paper and to see all the characteristics of this device. I really want to thank you, the fellow that I was working with at the time also. They did a phenomenal work to help us to put everything in place to be able to do that first in men. Chevi Fexa is now working in Barcelona. Apostolos was presenting this morning. He's working now in Greece. And I want to thank you also, my ECHO colleague, that I think if you need, for this kind of procedure to work as a team, that's a secret. Thank you very much.